Raquel, você fala espanhol ou vai falar em inglês?
Vai ter que ser em inglês, que não, ou português ou inglês.
Ok.
Mas pode ser inglês?
Sí,
No hay
sí,
problema.
of course. Yeah.
Español comprendo, pero no lo sé hablar.
E gallego, não pode...
Thank you very much. I am honored to introduce Raquel Menezes. She's Associate Professor with habilitation at the Department of Mathematics in Minho University in Portugal. Her main research interests are spatial and temporal statistics and its applications. She has been acting as principal investigator of projects funded by the Portuguese National Funding Agency for Science, Research and Technology, and being member of other funded projects. In the last 10 years, she has supervised 5 PhD students and published about 22 papers in international peer-reviewed journals. She will open this session about modeling the COVID-19 pandemic with a talk whose title you have in screen. Please, Raquel.
So, buenas tardes a todos y perdón por no hablar español. But I need to speak English, otherwise I think you will not understand me. Anyway, at any point that you wish, you can stop me, okay? Please. So first of all, I want to thank Javier Tejos for giving me this opportunity of sharing this work. Okay, so this is very nice from him. And in fact, I am a small piece in the puzzle on this project. I think you can see my mouse, no? When I point. So this is a big group of people and I'm a small piece in here. But anyway, and my area of expertise is not COVID, like Javier has mentioned, is spatial and temporal statistics. But I think we mathematicians, we statisticians in the last 2 years, I think somehow many of us have done something related with COVID-19 due to the importance of this theme. Anyway, so you are seeing my slides, right? And this is the outline of my talk. I will start by explaining who is Corona Surveys team, okay, and how it starts. Then I'm going to mention, I am going to focus on a particular work, more recent work, very recent work, and I'm explaining the methods on this contribution, this work, and some results about the impact of Omicron variant in both South Africa and in the world. Okay, how it start? So 2 years ago, more or less, almost 2 years ago, in March of 2020, at a certain point, we were really, I think, not only in Europe, but in Europe, it started more being in Europe, no, after China. And in particular, here, what happens in this new, in the El País, is about Spain, who had already more than 3,000 cases of COVID. The question that was in our minds is, okay, this is the number of confirmed cases, but how many real cases exist? And in fact, I have to move the windows to another, okay. And in fact, in particular, this new is from March, March of 22, and there were an increase of almost 1,000, okay, so it jumped to 4,000 more from this number, so more than 1,000 in one day. This is really worrying. So there was a rapid growth at the early stage of the pandemic outbreak, and it was very hard to keep up with testing, doing testing. And this leads to reporting delays, not only in Spain, but all over the world. Problem, it was worse when you talk about low and middle income countries. So this is even more worrying. It was important to find a way, a simple and timely way, cheap as well, of evaluating incidence and evolution of epidemic in a given country. And the idea was given by someone from the institute that was I would say, the father of the project, which is the IMEDEA Networks Institute in Madrid, in Spain. We propose a very simple idea. So using social networks like Twitter, the question was to ask people, do indirect reporting. So to ask people, how many do you know that have COVID? Okay. And in this particular case, people had only to answer 0, 1, 2, 3 or more, just this, a very simple question. Let's see this example. There were a total of more than 700, so 732 votes. And what this allows us to do? It allows to, okay, we have here an approximation of number of cases, and this number that is in here, which is 150, is a number that comes from social journal that says in average, each of us know 150 persons in average. So this is a number given by researchers from social areas. What this allows us to see that if we have this average number, this number, we'll have a reach of 732 multiplied by 150. And number of cases is this, and knowing the population of Spain, we can have an estimation of how many people in fact have COVID. And this is really frightening because we are talking, this particular case, it was 30 times the official number that Spain was reporting, okay? So the official number was bad, but it was really underestimated. What is the idea of these indirect surveys? The indirect surveys is when the participants' answers, they are not about themselves, but about their contacts, okay? And this is nice to use when we are talking about sensitive topics. For example, if we are talking about drugs addicts, if we are talking about illegal immigrants, okay? We are talking this kind of some sexually transmitted infections. It was where it won the idea of indirect reports. If we're talking about this kind of sensitive topics, it is important to use these indirect surveys, okay? No personal data appears, no GDPR issues, although there is some ethical board approval, and it is really cheap and massive data collection. Why? Because it's very easy to scale up, okay? It's a network scale up method. This is the advantage on the top of this slide, but we have here some limitations as well. It is, we can say, an orthodox approach because there is no panel selection, there is no stratification, okay? So the sample is not representative. Everyone, I think, would agree that the people that use, for instance, Twitter is not representative sample of all population. So there are limitations like these ones. And moreover, it's not possible to track answers from users across time. So there is no longitudinal studies, you see, and we may have fault injections. So these are the limitations, but in fact, it was a simple idea that allow to estimate, to monitor the incidence of COVID-19 via open surveys. Who is this team, the Corona Surveys? Okay, it's a collaborative endeavor. It joins several universities, research institutes. We have here the logos of some of those institutes. My university is this one, is the Minho University, and the one that was the owner of the project, where most of the people is this IMEDEA Networks Institute that is in Madrid, as I mentioned before. So what I just explained was the beginning of this. So it was 2 years ago, and it was with these indirect surveys. More recently, and I have here some numbers. For instance, how many people, more than 30 researchers, which are computer science people, statisticians, even epidemiologists we have in the team. And the current numbers are, we have open surveys available over more than, it's about 57 languages. So it's possible to participate any country in the world. You can take a look to the web page, sorry. So the web page is this one, coronasurveys.org, and it is really easy for many languages to answer to the survey, which is not that simple as I just point on the Twitter. Now it has more questions, okay? My point for today is not the indirect surveys. My point for today is to talk about new collaborations that happened like half a year ago, and new data sources with a lot of potential. There is a lot of very nice data with these new collaborations. We are talking about collaborations with the University of Maryland in the USA and with Facebook. So this data, the data source, I will from now on talk about, when I say Facebook data, is this data, okay? So data from the University of Maryland, and it's COVID-19 trends and impact survey. So it's surveys that run on Facebook, and they are thousands and thousands of records of entries on this survey. And the data is very rich. Moreover, we also have this public site, okay? This is a public site. You have here the coordinates, okay? GSED.org, which also has some variants sequencing, okay, which is important to see which is the variant that nowadays dominates. Is it Omicron? Which is the variant that nowadays dominates? Okay, so this is the present, and if we go a little bit back in the past, you see that we have here some work done in 2020, and most of this work was more about indirect reporting, okay? I'm going to talk about this one, which is from January, 1 month ago. And the idea is exactly like the title of my talk, using survey data to estimate impact of Omicron variant on vaccine efficacy, okay, against the infection of COVID-19. This is the topic. So the motivation for this work is, okay, we were in December, or if you go back 2-3 months ago, in South Africa, the Omicron variant was detected, and Omicron was spreading very quickly because of higher transmissibility, but also because it escapes to vaccination. So vaccination was not efficient for this particular variant. In early December, the Corona Surveys group started exploring characteristics of Omicron with this Facebook data. And in this Facebook data, there were symptoms, there were prevalence, there were vaccine escape, okay? Still in December of 2021, these colleagues, these researchers, they use part of this data to estimate vaccine efficacy, and they show that it decreased with 2 doses in a particular region of South Africa. So this was first work about this Facebook data, one of the first works about this, and testing the presence of Omicron. Let's talk a little bit about this Facebook data, these cities data. It is self-report survey data, so each person is not indirect, each person responds about himself or herself. And in fact, since spring of 2020, University of Maryland, in collaboration with Facebook, has collected a lot of survey data on self-report symptoms, infection, testing, behavior, and more recently, also about vaccination status, okay? Here, in this work, in this talk of today, I'm going to show what you used when we use a part of this Facebook data. And the idea was to derive an improved proxy for COVID-19 active cases. So the idea was we wish to estimate the number of active cases of COVID-19. That was the idea. And this is done using a machine learning algorithm. In particular, is a random forest technique, and it allows us to track closely the evolution of confirmed cases. Starting by what we consider to be the main contributions of our work. So it's being proposed a machine learning, a random forest-based proxy of positive cases. As I said before, the idea is to study the vaccine efficacy, but against infection for several levels of vaccination. Are you talking about one vaccine, two vaccines? Okay, this data is in the survey, so this is will be used. And it will study data from South Africa in 3 time periods, because things change a lot over time. So it is important, as I will explain later in depth, to study these in different periods of times. And moreover, we will also apply these techniques to other countries besides South Africa. Okay. There are alternative classifiers. Let's remember what is the goal. The goal is to decide if, according to a given answer, a given record in the database, in the survey, the idea is to decide if, according to the symptoms, is a symptoms-based classifier, okay, to decide if it is a positive case or not. And we are going to use some previous approaches. One, in this work, FANIO 2020, a response is considered positive, so a case is considered positive for COVID if the people answering has fever along with cough and or shortness or difficulty of breathing. Okay, this is one of the classifiers. According to these symptoms, it is classified as positive. Then from this work in here, from these colleagues, a case is considered positive if there are 3 possibilities. The first possibility is if the respondent answered yes, had an anosmia, okay? Plus one of these 3, fever, muscle pain, or cough, okay? The second possibility, the respondent has cough, and plus one of these 3, okay? And the third one, muscle pain, and one of these 3. Otherwise, it is considered a negative case. So this is the alternative classifiers. However, there are some limitations for these previous classifiers. They do not take into consideration the uncertainty of the diagnostic, okay? Sometimes the same set of symptoms might be associated with some other condition. And at the same time, they are not adaptive to possible changes over time, because in fact, over time, the symptoms are different. As examples are here given, as vaccination rates increase or new variants emerge, okay? So full symptoms change over time, and we cannot be, you must be flexible, okay? We cannot always assume the same symptoms for different periods of time. taking into account these limitations from previous classifiers, the idea was to suggest a random forest classifier where the answers of people that answered yes, they had COVID, they were used to create a ground truth set. Okay, so responses of users in the ground truth set are used to train a model. This is then used to determine the status of users outside the ground truth. So this is the thumb idea. So the idea is this one. And we wish to compare each of previous classifiers, each of previous proxies. I will call them proxies of number of cases, active cases of COVID. And the idea is to compare those with the estimate of active cases obtained from official number of cases. Okay, so there is also information according to this paper, by the way. This paper is also from Corona Surveys team, and which the one that takes into account that there are more active cases that we see in the official data. Okay, and the idea is to compare these alternatives, previous one, so these four, plus the new one against an estimate of active cases obtained from official numbers, to compare all those. Let's see a summary of the random forest technique. The machine learning model to classify Facebook survey responses as positive or negative cases, then creates ground truth set from these questions. There are two specific questions in the Facebook survey. The first one is, have you been tested for COVID-19 in the last 14 days? The second one is, did your most recent test find that you had COVID-19? So using these two answers, we can create the ground truth set. Okay, this ground truth set is used. Let me see. Javier, can you please explain what it means of the bell?
I think it's time, but we have time until 9:40. We have
okay. Can I go for 10 minutes more? Is it okay?
10 minutes more, yeah, sure. And then we have 5 minutes of questions.
Okay, thank you. Great. Okay, and so let's go to the, maybe in here I can jump. And a bit to understand the performance of these classifiers, okay, we have here 5 classifiers. The one proposed is random forest against the other 4. What RC doing is to split the ground truth in 70% for training and 30% for testing. And we have here some measures of quality, okay, according to this division that we have in the bottom line. And we can see the highest values are in bold. We can see that the proposed random forest has a good performance. Okay, some results that we have in here. Still for evaluating the classifiers. What we have in the first 2 columns? In the first 2 columns, we have the test positive rate obtained from, this is the our world in data. So this is public data, public information about the TPR, test positive rate. And we also have a second column, this second column, which is calculated from the Facebook information. Okay, these are the Facebook surveys. Okay, Facebook surveys is calculated from here, and this is our world in data officials. And the other 5 because they are 5 classifiers. The other 5 columns, we have here a Pearson correlation with the confirmed. So each of classifiers is being tested for the association with the confirmed time series. Okay, and I would like to highlight cases like where this correlation is quite good from the classifier random forest and the confirmed in case of Italy. And what is important to see is there is some coherency between the results, the official result, and one given from the Facebook surveys, okay? And more than that, these values are small. They are smaller than 10%, okay? This means that the sample is representative of the population. If we have a number, like for instance, in India, where is India? In India is not the highest one, but we have cases, oh, for instance, South Africa, this is 24, okay? These cases are too big. So Italy, we can trust on these results because they are really, when we compare these two values, they are similar. In case of Russia, we cannot trust this result because these are too different, okay? Now some information about prevalence and efficacy estimation. What we can see, and this is standardized, so we have prevalence in here. We are comparing the 5 classifiers and the confirmed case, and we see they go together. The exception is more or less in here. And please note that in here we have, it was November of last year, there are very few cases. So it's hard to work with this time of the year, November. I will show a result that is impacted by this lack of information in one of my further slides, okay? So vaccination levels, we can classify these. People are unvaccinated, they are vaccinated, they have 1 dose, they have 2 doses. How can we do for each of these levels? We can have time between correlation. Sorry, I should have a clock near me. Okay, now I see my time. So we have the vaccine efficacy. What we have in here, suppose that the vaccine are very good. If they are very good, this means that prevalence in vaccine will be 0, and the vaccine efficacy will be 1, the maximum. If the vaccine doesn't matter, the prevalence in vaccine and in vaccinated people will be the same, and this will be 1, so the vaccine efficacy will be 0. Okay, so vaccine efficacy goes from 0 to 1. 0 is when it doesn't do anything, 1 which is the best. With this vaccinated prevalence in South Africa, what we see is when we look at July, the prevalence was higher, and when we move around time, and now we are talking about January, okay, of 2022, December, when we see this blue line, what is the blue line? The blue line is people not vaccinated, and the prevalence was a lot higher, okay, for people not vaccinated when compared with people vaccinated. Unfortunately, when we go to December, the prevalence was more or less the same. So vaccine were not working, okay, this is different. And here on the left side, we have the proportion. This is data from surveys, Facebook surveys. We have the proportion. Okay, what about efficacy? What happens? When you go to July, September, the efficacy was high, okay? Was almost 1, no, not 1, but 0.75. And when you go to December, the efficacy was going down. In here, we have noise, okay? Because November, there was not a lot of data, but the big pattern is the efficacy is decreasing over time because of Omicron. And we can also see this in this table, because in this table, what we have is, we are talking about confidence intervals for 95% confidence intervals for efficacy. And let's see the case of having 2 doses of vaccine. And if you see in June, July, the efficacy was around 7.76. But when you go to December, it was only 0.3. Okay, so there was a big decrease, even for people with 2 doses. There was a big decrease of efficacy over time. You are talking, these results are from our classifier, the random forest classifier. And one of my last slides is this one with picture, is this one where we are plotting on this x-axis, we have the prevalence Omicron, okay, over time, no, sorry. So in here, what we have is when the prevalence is over time because Omicron started appearing more in December, so November, December. So in here, Omicron prevalence was very low. On the right side, the prevalence of Omicron was very high. And this is public data as well, okay, from one of the sites that I mentioned before. And what we have here is the efficacy. Efficacy was here around 0.7, and it is decreasing the trend. We can see here a trend, which is obtained through lowest curve fitting. And we see that the efficacy is decreasing when the prevalence of Omicron is increasing. There is a negative association between these two. So this means that, in fact, the efficacy, the vaccines are not working for Omicron variants. Summarizing, I think I will focus on some important open problems. When we classify having COVID, not having COVID, only testing positive or testing negative. I will end up in 1 minute. And in fact, it is important to understand how if people become very seriously ill or not just having COVID or not COVID. Okay, so there are a lot of opportunities of working with these very rich data. And I have here in appendix some numbers of the survey responses, just to give you a picture of how big is this data set from Facebook and the potential that we have in here for analysis. And thank you very much for your attention. Okay, the work, if you are curious about this, is in the Med archive, and you can see more details and send me a mail or how you prefer if you wish to know something more about this work. Thank you, Javier.
Thank you very much, Raquel. We have 5 minutes for questions. I have a first question in slide number 5. When you began to talk about the way you get the data, for example, in the survey on Twitter. This is number 5? No.
Indeed. No. Is this one?
This one. For example, what happens with the duplicated data? Because it may happen that the same person is reported by 2 or 3 different people.
Yeah, this is not robust to that. This is an important point. You are completely right. So this is a very rough, not about repetitions. The idea is, if you do it a lot and if you do it in different publics, okay, and if you count it twice, okay, you count it twice also in the bottom on the numerator and the denominator, you see? Mm-hmm. It's not ideal because we are doing it more than 1 time the same, but anyway, you are counting it in the numerator and the denominator. But there are limitations on this, no doubts about, because we're not guaranteeing that we have different people, and the representativeness is not also guaranteed of the sample.
Mm-hmm. Okay. Any other question or comment?
I also can add, if you don't mind, sorry, about this number, which is something that we also try different approaches, because we even try to ask people 2 questions. How many people do you know? How many people do you know with COVID? And how many people do you know? But of course, people, if someone asks me or asks you, how many people do you know? People gives a very rough answer, I would say, no, because you are not really sure about it. So even in here, there is uncertainty, no doubts.
Yeah, sure. And how do you estimate the people that doesn't have social media?
We don't, because, okay, but in fact, you know that some limit countries, so when I talk about countries like India, there are, even from there are a lot of people answering. Nowadays, there are a lot of people that maybe they have some kind of way, a method of answering, but if you don't have a social, that's why it's not representative, okay? But anyway, there is a lot of information from here, from these indirect surveys. More than we, at least in our case, even in Brazil, I remember, there were many people answering. You have there someone from, in our team that is from one university in Brazil. And it is important to motivate people, okay? For instance, in Portugal, I confess that we had difficulties of putting people to answer in Portugal, but in Spain, no, people really are wishing to help and answering. So it depends also of how much advertisement you do, you see. But I believe more, this is old, so this is the past. I do believe more on this type of information where we are talking about, even in Facebook surveys, these surveys that people answer with a lot of questions. Of course, there is some noise in here. There is always noise in surveys, but we try to clean those. And we are really surprised, well surprised, when we compare with what is given from these surveys from Facebook with a lot of questions, and when we compare those with the official data, there are a very good correspondence. So the data from surveys don't lie that much. It was a positive surprise, I would say.
Yeah, okay. I don't know if there is any question. Michael, Agustin? We have colleagues in Costa Rica who work also in some classifiers, but with different methods. Okay. Sorry. Hay una pregunta.
If you prefer, Javier, you can speak in Spanish.
Javier Ramirez, I don't know if Javier is from Mexico. Is the Javier Ramirez I know? I don't know. Do you know if there is any prognosis if this can degenerate into a flu?
Okay. The question, because it's on chat, you are reading from the chat.
Yes.
Probably. Okay. Okay. So, in fact, the symptoms are the ones that are being, that's why it's important to change them over time. So it's important to train on different periods of time, because the answers that we get in a certain now are different from 2 months ago or 3 months ago. Okay, they are different. And we train the data using those cases with people with COVID, you see? So some people say, yes, I had COVID, I was test positive. And what were the symptoms? Were these ones. So this is the training act. This is to build the ground truth set. Of course, that when we go to the ones that we don't know the answer, because they only have symptoms, okay? They didn't answer about having or not having been tested about COVID. We can mix these with what was the illness that you mentioned?
Flu.
Flu. Yeah, we can mix this with flu. It's not impossible, but we believe that with the ground truth answer, okay, we can train the model, and the results when we try to figure out the accuracy and these indicators, they show that, okay, it behaves quite well, but it can be mixed with the flu. Yes.
Mm-hmm. Mm-hmm. Okay, thank you very much. So I think we are in time. So thank you very much, Raquel, and thank you very much to all of you. In some minutes, we will continue the session. Now we have a coffee break if you have coffee at your home. And in 7 minutes, we will begin with the talk of Santiago Núñez. Thank you very much.
Thank you.